So yes, my name is John Howie. I'm a service manager for place-based working and health and all policies within Public Health Scotland. And I'm sure a lot of you will know about the organisation, but I thought it'd be worthwhile just sharing a little bit about who we are. We were established in 2020. What a time to be established as a public health organisation, because it was just when the pandemic kicked in. And it was a consequence of 3 national boards coming together, one of them being NHS Health Scotland, which I was a member of. And we as an organisation are accountable both to the Scottish Government and COSLA. And the 3 overall priorities, no great surprises in public health, is around how we protect health, and that was a big focus around the COVID. And improving health, which is a focus of the work that I am responsible for, and indeed reducing health inequalities as well, which is everyone's business, and of course your business in this room. We currently work to a 3-year plan, but the plan is for a 10-year plan that we'll be working to between 25 and 35. That's currently being developed internally. And we've got a budget of about 48 million and over 1,000 staff. Just to put you in the picture in terms of where the CHES work sits, within Public Health Scotland, we've got 4 directorates reporting to the Chief Executive's office. Within Population and Health and Wellbeing, there are 4 services, and I'm responsible for the service area of place. And that's where CHES will sit in. But it's everyone's responsibility to support this fairly complex programme. So why the collaboration for health equity? Well, it's not a challenge that's unique to this programme. You'll have seen these graphs coming up time and time again. And where we're working this today, you will see various statistics that outline the challenge that's been in existence for a number of years and is at risk of growing even wider. This is healthy life expectancy using the National Records for Scotland between 2019 and 2021. And you can see both for males and females that people living in the most affluent communities have got twice the number of years of feeling healthy than that of those who are not. So in terms of females, you can see that in the least deprived, 13.2 years experiencing unhealthy episodes, whereas in the most deprived, that doubles. So you can just think of the amount of time that people are unhealthy for. And that plays out as well for males. It's twice the number of years. And that also is illustrated in terms of not just healthy life expectancy, but life expectancy as well. And again, you can see the differences there. Now, of course, what contributes to health, this has been well rehearsed. We're very much familiar with what that means, and we can draw upon a whole range of different frameworks that will help explain what contributes to our health and well-being and what creates inequalities. Anything from the Sustainable Development Goals at an international level. And if you're familiar with them, you know if you go behind each of these boxes, you get a thorough explanation in terms of the evidence that would support things such as peace and justice, no poverty, reducing inequalities. And indeed, in Scotland, the National Performance Framework recognised that framework to outline how it would monitor and report on progress across Scotland. Or it can be more academic frameworks, such as the building blocks for health and well-being, recognising the whole range of different drivers of what have an impact on our health. Or if we want to go really old school, we can go back to 1991 and the Dahlgren-Whitehead model. But again, explaining the exact same factors and the interrelationship between each of those that will determine our health and well-being. Practically, how we take that complexity forward and work through our programmes of work, then we can sometimes use tools such as a place standard tool, which simplifies that complexity and invites communities and other partners to look at what works well within your place, the things that could be improved upon, the priorities for change, and who should take that work forward. And I suppose that is the big challenge, is who takes this work forward in a coordinated manner. It's everyone's business to take that forward, but sometimes there's a number of challenges that we're faced that makes that not so easy. This is from the Scottish Prevention Hub, and I'm sure when you think of the previous slide, the challenges within our communities in terms of health and how we get on with business, that some of these things you can relate to in your day-to-day work. I'm sure there'll be a series of scenarios where one of those collaboration challenges has come into effect. And that's very much what this programme is about. It really is very much around committing to improving not only the well-being of communities, but how we work as organisations to come together and do that challenge and address that challenge in a united way. So the two big questions for the Collaboration for Health Equity in Scotland is to answer what are the most impactful areas for intervention for Scotland to make meaningful progress in closing the inequalities gap in healthy life expectancy. And then secondly, it's all around about how we do that. What action can be taken to enable national and local organisations to work more effectively together to close the recognised implementation gap between our policy ambitions and actual delivery on the ground. And again, you will probably reflect, and no doubt it's been mentioned at conferences such as this, is we've got great policies in Scotland, but the challenge is always how we actually can implement that on the ground and for it to have impact. So to answer those two key questions, of course, as a national organisation, Public Health Scotland and the Institute of Health Equity from University College London, where the Marmot Places originates from, we require local colleagues to join in the programme of work. And in autumn of last year, an invitation went out to the 32 local authority areas. And the invitation was around, would you be up for designing your work around the key Marmot principles? Are you willing to embed these challenges within your day-to-day work, be it at a policy delivery or improvement level? And secondly, with the Marmot principles, are you willing to make system change within your local area and are up for significant cultural shifts to allow a transformational process to occur? Sorry. Okay. I'm sure that's better now, isn't it? In fact, I can hear it's better now. Thank you for that. Okay, so with that invitation, we got a response from 12 areas. And as John said in the introduction, we went through quite a significant process for coming to a final decision that Aberdeen, South Lanarkshire and North Ayrshire would be the three areas that would be focused on. The initial work will continue up until June 2026. It is a 2-year programme that started last year, but we wouldn't expect it just to stop there. It'd be hardly surprising if there was a move to continue with that work. And where we are just now is in the last few weeks, the launches have occurred within the local areas. To take those ambitions forward for the programme. And one of the great things about the selection process was the conversations that were taking place. And indeed, some of the asks that came out of that process aligned to the ambitions of the programme that will help us nationally consider what our focus should be for supporting local systems and taking the work forward. So you can see there in terms of the local areas seeking very much support around independent expertise, support around evaluating the impact of what's done locally, really looking at how we can support resources being better aligned to the priorities within local areas. And a request to support the challenge of proportionate universalism locally. Both in terms of how it's delivered, but how palatable that is to the public. Sorry, I can feel this microphone slipping down again. And just on proportionate universalism, I know many of you in this room will be very familiar with it, but it's just really how we respond to this scenario in terms of, once again, an illustration around healthy life expectancy and how and the ages for the most deprived and the least deprived in terms of the number of years you will feel healthy for. And the response to that in terms of proportionate universalism being very much, if you're wanting to move from this to a more equal distribution of health, then there's a need to invest more here in our most deprived areas to allow that to happen, and less so in the least deprived areas. And that can be a challenge in terms of how you do that as a process, but also how acceptable that is to communities. There were other areas as well that were highlighted in terms of what local areas would like to get out of this collaboration. And one was around that closer engagement with the business sector. Discussion at a national level around reform, around funding. And also some very practical things is, how do we engage with national systems, national organisations to get the support we're looking for quickly and effectively. And finally, around building capacity across organisations to take forward a whole range of different approaches that would be helpful. From my own perspective, it would be how you build capacity to take a place-based approach to solutions, or indeed building capacity how to carry out health impact assessments. So looking at what are the health implications of the plans that are developed at a local level. So I'll stop there, other than share with you a few things that are probably worth noting. One is in terms of where we are with the programme itself. We have now got the national governance structure established with a whole series of different groups. We've got the Places Board that brings the national teams together with the 3 local areas. And of course, at a local level, the 3 areas are beginning to develop their structures as well for implementation. In terms of how this operates differently from Marmot Places in England, is that unlike down south, where the Institute for Health Equity went into local places, did their evaluation and produced a report at certain times, Public Health Scotland will remain with the process throughout, and any learning that's emerging live, we will take that and respond to it. We will also respond to any asks that come out of the local areas as well. So it's slightly different in terms of what the design model is. And to ensure that everyone is aware of that learning as it comes out, we have got a chess learning system. And if you are interested in ongoing updates around the programme or want to join the webinars, then please email that address. I think slides will be shared, and this has been recorded as well, so you'll have access to that. And if you're interested in the broader UK work around this, then please just go into that link, and that's probably less helpful for writing down, but you will certainly be able to access the network at a UK level. So thanks for that. I will pass you over now to Wendy, who will share thoughts from a local perspective in South Lanarkshire. But if you do want to, the final way of getting in touch around this is either contact myself or our new organisational lead in Public Health Scotland, Caroline King, who was just appointed on Monday. Okay, thank you.